Hello, everyone. Welcome to today's webinar. I'm Ling Xu from the marketing team here at Amwell, and I will be your host today. We're so glad you're joining us for today's conversation on 3 ways that Amwell Medical Group delivers care quality and reach. I have 2 leaders here from Amwell Medical Group today to provide insights on Amwell's proprietary medical group, what makes them so effective at supporting care access and a high quality of care for better outcomes. Before we jump into all of the amazing content that we have developed for you today, let's go over a couple of quick housekeeping notes. First, we are recording this webinar, and that will allow us to circulate the recording after we wrap the session today. That way you can refer back to the conversation. Secondly, at the bottom of your screen, you should be able to see a Q&A box. Please feel free to submit questions into this box at any point. We will have dedicated Q&A time towards the end of today's session. And as we go, you may find that we address any questions that you have anyway. All right, wonderful. With that, let's go ahead and get started. Amwell is a proven, trusted partner in delivering technology-enabled care. We were founded in 2006, which is almost 20 years ago now. So we have about 20 years of experience and know-how delivering technology-enabled care for health plans and health systems. We help health plans enable their care vision and are leading the way on what's possible for the future of care. For example, one of our partners is actually the DHA, the Defense Health Administration, and they cover all of the lives of the men and women in uniform. So that's just to go and show you the level of trust and security and measures that we have in place to ensure that we are online and ready to support your members. We currently work with over 50 health plans, and their memberships are national and regional, ranging from thousands to millions of lives. Raise your hand if you ever felt like this, confused, not sure where to start when you're navigating the care universe. I mean, I definitely have. Consumers are now going online for everything, and that really does include care, but they're still not really sure where to start, not able to navigate to where they need to be between this website, that website, this app, remember their login and password information. In fact, over 50% of customers have opted out of seeking care because they really weren't sure where to start. And what that means is you're losing people at the very beginning. Members are going online for care, they don't know where to go, and they drop out of the funnel. Meanwhile, you've invested in all of these amazing solutions to support your members, but they're not working. They're not even getting a chance to work because people can't find them. And that's really what Amwell is here to help solve. With Amwell and you in partnership, members will have one place to go for care so you can realize the value of your investments and achieve improved access, better outcomes, and reduce costs. And we'll walk through some of how that works today with Amwell Medical Group. But at a very high level, I just want to set this up for you before we get into the deeper conversation. Amwell brings unified access from your member portal into a platform that allows access to a whole set of virtual whole person solutions that's fully integrated into and taking into account your like health plan design, your network, everything that you have already in place. We connect your unique data and intelligently drive a member experience that's integrated into your assets. We're capturing longitudinal data that on everything that happens to your member in this experience and use it to continually improve. And then we share that information back with you. And surrounding this and supporting this entire platform is Amwell Medical Group, a 50-state clinical group powered by all of your preferences, all of your members' medical history, and more. Our two experts with us today are Cynthia Horner and Nicolette Salinas. I will go ahead and let them introduce themselves. Cynthia, could you go first, and then we'll turn it to Nicolette.
I sure can. Thank you, Ling, and welcome to everybody. So my name is Cynthia Horner. I am a family physician by pedigree, and I'm Amwell's Chief Medical Officer and the President of Amwell Medical Group. In that capacity, I'm the lead clinical voice for Amwell. I'm accountable for the oversight and implementation of all of our clinical services and programs, including our virtual primary care, urgent care, behavioral health, women's health, nutrition, and lactation, as well as any new clinical offerings that we bring on board. And in my capacity as president of Amwell Medical Group, I lead a multi-specialty team of several thousand clinicians and really collaborate closely with our Amwell product team to drive that technology-enabled, value-focused clinical outcomes. So I'll turn it over to Nicolette.
Hi there, I'm Nicolette Salinas, Vice President of Provider Operations at Amwell and Amwell Medical Group. My team and I take care of all of the day-to-day administrative and operational aspects of care delivery for Amwell Medical Group on the Amwell platform. I've been with Amwell since the start of the medical group, about 2013, and prior to that, have experience in health plan operations.
Wonderful. Well, thank you so much for joining us today, and I'm so excited to get started. We'll jump straight into our first question. Cynthia, could you, this is an easy one, can you give us an introduction to Amwell Medical Group?
I sure can. In order to do this, exactly, let's go to the next slide. So this is perfect. So Amwell Medical Group is a long-standing medical group that really our primary driving factor is quality. We were first founded in 2012, went live in 2012, 2013. We're NCQA accredited for credentialing, and we were the first to be ATA accredited along with Amwell, our technology platform. We have 2,300 licensed clinicians across all 50 states, and that's in several different business lines, including, as I mentioned previously, urgent care, primary care, therapy, psychiatry, nutrition, and lactation. And our women's health offering is a combination of those particular business lines. We really focus on connecting members to condition-specific programs and specialists that really are excellent within their area of need. We are online 24/7, 365 as a medical group. Predominantly, that's in our urgent care business line. And just at a really high level, we are extremely highly rated by our members, and that for whom we provide services with a 4.9 out of 5 member rating. And that's consistent since we started. So that's the general overview, Ling.
Amazing. Thank you, Cynthia. And I really think that member rating is incredible because we all know that is just so hard to get. People have such high expectations these days. So hats off to you and your team.
It takes a village, and we'll talk a little bit later about how we do that. So
perfect. All right, next question is also for you. So at a high level, today we're talking about the 3 ways that Amwell Medical Group provides value for payers. Can you just highlight what are those 3 ways, or how do you think about them?
Well, a couple of different ways, actually. We really focus on quality and quality of care, and that's really driving specific clinical outcomes. We want to support our client members' experience, so it's that member experience, and of course, all of this comes with the value of driving the cost of care very efficiently, so that we are not creating excessive overutilization. So it's cost of care, it's the quality outcomes, it's the member experience, and as a part of that, we really focus on ensuring that that we address the holistic health of all members. And we'll talk about that also a little bit further. But one of the foundational aspects of this from the very beginning has been to ensure that members actually have access at a time and place that's convenient for them. So that whole 50-state strategy is really critical for us, and 50-state plus DC. So really critical. But what sets us apart is not just, yay, we have a group of clinicians within every state and demographic within the country. It's really that strategic optimization and the rigorous quality that we demand of our providers and expect of the outcomes that we drive.
Wonderful. Thank you so much. And I really think, I I appreciate you highlighting that strategic alignment and optimization piece. That really is very critical in my experience.
Yeah. You bet. And part of what that looks like is really just ensuring that we're working closely with our client, the payers, and helping to engage within their programs that they may have. And again, there's a whole host of ways that we do that. If a payer brings to the table specific programs that they would like to ensure we're referring into, how do we do that? How do we ensure that we're referring in network? How do we also provide a unified reporting capability? All things that we're going to really dive a little bit further into. But that's one of the critical pieces of the value that we bring to the payer market.
Amazing. Can't wait to get into that. First, let's cover a little bit of let's go in kind of timeline order. So I'd like to start with the access piece. Nicolette, you're VP of Provider Operations. How are you ensuring that members have access to these very fundamental services that they need?
Yeah, great question. And as Cynthia mentioned, that access and that supply is the cornerstone to what we offer. Two ways we think about ensuring we have that access. The first is provider supply, and the second is availability monitoring, making sure that supply we plan for is actually in place at a given moment in time. Let's talk a little bit more about that supply first. I think about it as a pyramid. You know, we have a strong group of national providers in place today that are ready, standing by, delivering care every day. The top of that pyramid are physicians licensed in 30 states. They are our blanket coverage that you are going to get 24/7, ensuring there's always a provider available in every single state. Next, you have per diem, scheduled seasonally. These are providers that are in high volume states. So we talked about 30 states for that blanket coverage. 20 of the states are high volume. And that means we need to add layers upon layers on top of any existing coverage to ensure that there's always someone available, that wait times are low. Then we get into our regional coverage. So we have a couple different flavors of that. We utilize the IMLC compact, as well as states based on volume. We hire part-time physicians and nurse practitioners, license them in 5 to 10 states, and schedule them on the platform during the times where we need them based on our historical forecasts. And then finally, we have well over 1,000 individual contract physicians and nurse practitioners that are available as needed, either seasonally, weekends, overnights, essentially to be called in when there's need in their individual states. This particular look is specific to urgent care, but I think you'll find the approach is really similar across different services.
I love this pyramid view. Thank you for sharing it with us. And then let me dig in a little bit on part two then. So this is part one, provider supply. Part two around access is availability monitoring, right? How do you do that? What are some of the things that you're really looking at, some of the tools that you're using?
Yeah, it'd be a great time to flip to the next slide. What you see here is our telehealth operations dashboard, and this is what our agents can monitor in real time in order to determine if volume is where we predicted it to be, if our schedules are being fulfilled, if patients, both as a cohort and on an individual basis, are waiting for the appropriate amount of time, and then act accordingly. So if wait time is higher than we designed it to be, there are protocols in place where the team monitoring this dashboard will be able to call in reinforcements, essentially. This dashboard knocks up against what you see an example of on the right, and that's our forecast. We create forecasts, which then turn into staffing models that look at day and time, seasonality, state, marketing initiatives, any hiring practices or bonuses we have in place. And that allows us to be really strategic about the places that we are putting our providers and how we're matching them with patients. That allows us to have our access available, but also ensuring we have really strong industry-leading wait times when we set up our supply demand.
Thank you so much, Nicolette. I have to admit, when you were talking, it really did remind me of kind of like some of those other consumer platforms that we use, like Uber and things like that. So I think that's great. And then I just wanted to take a quick look at the wait times that you're referring to, these industry leading wait times. And I think I have them up on the screen here. Less than 10 minutes for urgent care. And then for the other ones, I'll let you speak to those, I guess.
Yeah, so many of our patients can find same day appointments in most services. On average, we're looking at less than 7 days for a primary care appointment, less than 2 days for therapy, 7 for psychiatry, 2 for nutrition and lactation. And because our availability is so widespread, we find people are happy to, let's say, wait at 24 hours for an appointment in those behavioral health realms or for nutrition for a time and a date that works best for them.
Yeah. I also find that in talking to some patients, it's also about the provider, getting the provider that they want, or someone that they feel comfortable with. So I think that's also great that there's that flexibility built in.
Absolutely.
Let's look at overall availability. So say that I am, I feel like working 9 to 5, or say I have a job where I'm on call for 12 hours straight. Like, how do we also make sure that we're serving those people who aren't maybe able to make it into a doctor's office?
Yeah, and so you use the word flexibility. That is key. We offer hours that are flexible for members. Urgent care is 24/7, 365. Our business lines that require scheduling, so behavioral health, primary care, nutrition, and lactation, our standard hours are Monday through Friday, 8 to 6, with some weekends as well. But what's really critical to know is that patients and providers can also agree to meet at times outside of it. So we're not opening and closing the door. There is not something blocking people from meeting or having appointments and receiving care at other times. Those are simply what we consider our most available and most popular times.
Wonderful. I mean, I know that I'm a parent, so as a parent, sometimes I do want to meet really early in the morning or at night or other times. So I appreciate all of this flexibility that's really built in. All right, let's move forward onto our next question. All right, Cynthia, could you tell us what is AMG's secret to a good virtual visit? And AMG is for our audience what we refer to, the acronym we use when referring to Amwell Medical Group, because it can become a mouthful over time if you're saying it multiple times.
Well, thanks for asking that question, Ling. It's a really key question. Depending on how you define good, you could get different answers. So whether we're talking about driving the member experience, whether we're driving provider efficiency, clinical outcomes, or cost containment. So Amwell has put significant thought into designing a platform that addresses all of these criteria. But I'm going to come back to you and say, which one of those were you specifically thinking of?
Oh, the tables have turned. I take your point, Cynthia. Let's just say good is a high quality visit that supports outcomes and a planned strategy and overall design.
Okay, so you bet. You have a lot of ways that we can do this. So might be a good time to go to the next slide. Clinical quality really is, I mentioned before, driven by a whole host of activities, and it is not simply chart reviews. So when payers speak to any kind of medical group, they're going to hear about the quality processes that medical group, whether it's a virtual group or whether it's a brick and mortar group, what their quality management strategy is. And I can tell you, we could spend a good 45 minutes just on our quality management strategy, but we don't start with quality management strategy. We start with getting the best clinicians. So the columns the areas that we really focus on are recruiting and onboarding high quality clinicians and ensuring that we set the group up for success. We have a really detailed process for making sure that we're hiring the right people, that we're onboarding them correctly, also ensuring that they have ongoing peer support, that they have technical and quality care resources for success before they're even engaged. So we train them, and then we monitor them and follow up with them when they are or are not meeting what our expectations are. So all of this is supported by about a 60+ person operations team, many of whom report into Nicolette. So I could dive into each one of these special areas more specifically, but I'm going to pause there and see what bubbles to the top for you.
Yeah, I guess most commonly, like what are the common topics that the team supports, or what are the chart reviews, for example, that you're really looking at?
Yeah, so you heard from Nicolette about the operational levels of support. Some of the work that one of our teams does specifically to ensure that we're meeting our SLAs for wait times, that we are matching provider supply with patient demand or member demand, and providing that technological monitoring 24/7, 365 with our on-demand practice, also within our scheduled visits that providers are showing up for their visits. So there's that monitoring piece. But you looked more closely or asked more closely about what our quality team does. So our quality team really provides 100%, and that's no exaggeration, chart reviews on key clinical metrics. So 100% on some of these clinical outcomes metrics, whether it's clinically appropriate prescribing, for example, antibiotic prescribing in viral illness. Obviously, we shouldn't be doing that, so we want to monitor that. We don't just want to monitor a small smattering representative sample. We want to check every single time something like that happens. GLP-1 prescribing is a great example. We have policies around GLP-1 prescribing, and we want to ensure that we're adhering to that in any one of our prescribing business lines. We also do random chart reviews of a critical percentage of every clinician's records. So we look at it from two different angles. We look at it from what are the outcomes that we have to have great compliance on? And then what are we doing from a provider perspective? So we look at it from outcomes and metrics, but then we also flip the tables and say, okay, how are our providers doing across the board at medical decision-making, adherence to documentation requirements, and several other different matrices? And our clinicians actually receive a monthly scorecard of their performance against both our benchmarks, which are 90% of our criteria, 90% of the provider's behavior, and the chart reviews need to meet our established requirements against our benchmarks, but also comparing them to their peers, because we find 90%, we're really good at that. So we want to actually re-incentivize our providers to say, okay, great, you're at 91%, but do you realize that most of your peers are sitting at about 95%? And I can tell you there is nothing like competition to motivate your providers. So they tend to be a competitive group to begin with. So I'll pause there.
That's really funny. And I can see that. I mean, that would certainly incentivize me if you told me that everybody else was doing a better job. So I appreciate that.
Even though you're meeting our benchmarks, you can do better. Let's work towards that. So when you're not meeting benchmarks, then we have an entirely separate process for remediation and mentoring remediation, requiring continuing education and documentation of education, and all the way up to locking them until they can provide that documentation that they've improved. And then we have a continuous quality improvement cycle. And I'll throw some terms out there for the clinicians in the audience. We use a just cause model. So, and if you don't know what that is, we can talk about it separately, but suffice it to say, it's not blame oriented. It is really more improvement oriented.
Amazing. Thank you for providing a glimpse into the inner workings of what goes on and how you really have to pay attention to every little detail when you're running a medical group. I want to turn it a little bit to become a little bit more patient-centric or member-centric. Can you talk a little bit about how you're supporting each member, making sure that we're delivering quality care for them?
You bet. You bet. And this gets back to your question about what makes a good visit. So one of the key things that we as a provider group on the Amwell platform really rely on is the ability to ensure that we're treating these members as whole patients. So the way that we think about that, research shows that there are a myriad of factors that influence a patient's health. Their physical issues, their social issues, mental health issues. So someone with a chronic condition who also suffers from a mental health condition is 2 to 3 times more costly for their insurer compared to someone who just has the chronic condition. And that's when we talk about comorbidities and managing the whole person, that's really what we want to focus on. We want to focus not just on somebody's diabetes, but if they have a comorbid depression, it's going to be really hard to achieve those outcomes in managing their diabetes and improving their blood sugar, their basic blood sugar levels, if we're not addressing, for example, their depression. So that 2 to 3 times more, greater cost for comorbid conditions is really key.
That's an incredible statistic. 2 to 3 times, like the fact that it's a multiplier. You may as well invest a little bit more resources just to take care of that person, I guess. And do you know how much is that in actual costs? Do we have a number for that?
Yeah, actually, not surprisingly, there is some financial numbers behind that. Access to mental health care has been shown to decrease costs by up to about $1,400 per member per year for health payers, and we can share the evidence behind that separately. But suffice it to say that about $1,400, just under $1,400 per member per year, is actually significant cost. So, another example that we talked or that relates to this is not just mental health and behavioral health. It's also, what about social determinants of health, those health-related social needs? So a member's life experiences that can create barriers to them engaging in appropriate care. So we call those social determinants, or SDOH, and it's really critical to better outcomes. 80% of outcomes are driven by what happens outside of the visit. So maybe a member can't get transportation to the doctor, or maybe they can't eat well because they don't have the resources to buy healthy food. They could be living in a food desert, or they could just not have the money. So one of the ways that transportation is resolved, well, virtual care, that really helps that. But that only helps a part of it, because still sometimes members may have to go for in-person visits for testing, for lab work, for example. I haven't quite figured out how to do that virtually yet, but in terms of without a human being in the loop. But I suppose if we all live another 20 years, we'll see that. But for now, transportation is still a part of healthcare. So in Amwell Medical Group, we really take into account all of these factors and support members with clinical programs that are connected to and support the whole person.
Yeah, can you just speak a little bit at a high level about like what those are?
Sure.
Just very quickly.
Yeah, so Amwell Medical Group is multidisciplinary. So we leverage internists, family physicians, pediatricians, therapists, psychiatrists, nutritionists, a whole multi-specialty group to provide that strong foundation for fundamental whole person care. And primary care is really at the core of this digital care ecosystem. It's how whole care comes together. So primary care provider at the center, coordinating and managing the patient's care among all the other key stakeholders, whether it's the pharmacy, lab facilities for testing, specialists, and behavioral health providers. Our platform, which is the crux of how we manage this, really helps to connect us. So we have shared notes between the AMG primary care provider and the AMG specialists. AMG clinicians can directly enroll patients in eligible behavioral health programs, whether it's a digital behavioral health program if they're eligible for that, or any clinical partner programs that our payers might bring to the table. We have the ability to make sure that we are referring members to in-plan providers when we have the integration with the plan-specific preferred network. That's actually surfaced directly to our clinicians at the point of care so they can make those referrals appropriately at the time. So this whole person care is really critical. And I want to hone in a little bit more to our clinical partner programs and our in-plan preferred specialists, because with that API integration that I mentioned, all of that detail is going to show up at the point of care. It's going to influence that efficient cost and effective treatment decisions when the primary care provider is making them.
Amazing. Thank you so much, Cynthia. I think that's really key to understand, or that's really some of the secret sauce in how AMG providers are able to better serve the plan, better serve the member, keep everything in network on benefit, and think of things from that wider whole person lens, as opposed to just, I have this one issue I need to take care of for this one member at this exact point in time. So appreciate you speaking to it.
For members. Yeah.
Yeah, absolutely. And then I think, like, sometimes what we forget too is, I think, the power of seeing into someone's life or their home. Could you just talk a little bit about how an AMG provider is going about a virtual visit, and some of the benefits there?
Sure thing. So from time to time, a little less so than, back pre-COVID, but from time to time, we'll still get questions from often non-medical folks. Can you really do a physical exam in telehealth? And the short answer is absolutely we can. You only lose the sense of touch that clinicians would use. You don't lose your hearing, you don't lose your sight. And those are really critical. And we know how to get around the sense of touch by leveraging the member to support us. So we've known for years that there are a lot of benefits of delivering visits virtually and gaining access to a member's home environment. I used to do home visits back in the day, and there's nothing more powerful than seeing a member's home environment and understand to really help illuminate some of the challenges that they may be experiencing. So during every visit, we're really maximizing what we can glean from the view into their environment. We're looking at all kinds of things. What's in their pantry? What do they keep in their space? And how well maintained is it? And we can actually really understand quite a bit about some of the risks that they may be engaged in and things that they might not necessarily voluntarily tell us. So do they live alone, as best we can tell? Do they have kids that may impact their ability and their flexibility to manage different elements of their care? So we can personalize the interaction because of that information and find ways to connect with the patient and connect them to the care that they need. So, we're also getting information from their pre-visit questionnaires. So we have answers to those social determinants of health questions that are specific and targeted and not just sort of guessing based on what we see in the background, but we get the GAD and the PHQ questionnaires. So we really have validated assessment tools that give us some information. We have, of course, the patient provided information, but that plus the visual into their native space, whether it's their home or whether it's their workplace, these all really can help us gather information, and they're also customizable. So anything that our health plan clients want to specifically request, we have the ability, we will talk to you about that and really make sure that we're capturing that information in a way that is meaningful clinically and meaningful for reporting.
Amazing. Thank you, Cynthia. And then I guess that naturally segues into, okay, so once you figure out that somebody does have some kind of barrier or they need a resource, how do you direct that person?
Yeah, sure thing. And it really varies. So if we know that somebody has a health-related social need, let's go ahead and move. Yeah, thank you. If there are several different ways that we can address this. First, if one of our client health plans actually has a preference on resources that they want us to use, whether it's their own internal care management program, whether it's a 50-state social determinants or social services aggregator, whatever SDOH resource the health plan has in place, we train our clinicians to connect members to those. And we have specific ways that we can do that and surface that to the clinician at the time of the visit. We can also integrate those resources directly into the referral workflows. These health-related social needs could be related to a whole host of different things. So financial assistance, transportation, food security. And, it might help actually as I'm talking for me to give an example. We had a primary care patient several years ago who was housebound after hospitalization for COVID. He had really severe COVID and actually was in the ICU for several weeks. And he was discharged with outpatient physical therapy, but he was unable to access appropriate transportation to his PT. So he never got it. And so by the time his insurance came up again and gave him the virtual primary care option, he said, maybe this will help me. So he came to our practice and we were quickly able to first assess, okay, he's bedbound and has food needs, financial needs, transportation needs. We set him up with transportation services, in-home physical therapy, and respiratory therapy to support his rehab. Within 4 weeks, he was strong enough to leave his apartment and leverage the arranged transportation services to get to his pulmonologist for follow-up. And he had Meals on Wheels during that time, which really helped get him better. He said to us at the end of that course, when he, all of his in-home services had finished, he said, I don't know what I would have done. I'm not sure that I would be alive today if I hadn't had this opportunity. So that's obviously a dramatic example, but it's not unusual. It's the kind of thing that we will see in virtual care at least every several weeks and sometimes every week. If the health plan doesn't have specific resources that they've invested in for us to refer to, we will direct members to a specific social services aggregator, and we can talk offline which one it is. I'm happy to share it, but it's not relevant for today. There are several different aggregators that are 50-state aggregators of social services for SDOH.
Amazing. That was such a great example and great story, Cynthia. Thank you for sharing it. I don't think I've ever heard that one before. So
yeah,
very impactful, really highlights the importance of what you and your team are doing. All right, and then let's talk a little bit about, I want to hone in a little bit more on outcomes and the reduction of gaps in care. And we know that these are key cost drivers, essentially. How does AMG really do that?
Yeah, you bet. So first, we are going to align with the health plan on their priorities for HEDIS measures and gaps in care. Of course, all of our plan colleagues on this call are aware that there are hundreds of HEDIS measures that we can keep track of. So we really want to make sure that we are attending to a health plan's primary focus. And honestly, the top 10 tend to be common across most plans. You're going to have some preventative services and those that become critical gaps in care. And you're also going to have some that are key drivers of cost. So the whole person care really is augmented by ensuring that we're referring to sources that can address these if Amwell Medical Group is not capable of referring to them. So from a gaps in care standpoint, we actually capture information both at the point of visit in conversation with the member, and we enter that into a gaps in care tracking, I'll call it a widget actually, within our system so that providers can actually see in subsequent visits, and so that we can report out on what is a member telling us about their preventative services, or did they actually get the vaccine that we ordered for them at the pharmacy? Their pneumococcal vaccine if they're in the age group or the risk group. Have they had their mammogram yet? Okay, well, our plan listeners, our payer listeners are all aware also that claims are what drive the closure of gaps in care. So for payers that are able to collaborate with us to share claims data through an API integration, we actually can surface that to our clinicians at the time of the visit as well through a co-build. And that enables our clinicians to really be informed on actually not only what the patient says or what we know we've ordered, but also has it actually been achieved. So that's critically important. We leverage on-benefit third-party programs or clinical partner programs to ensure that we're addressing many of these things, in-plan preferred specialists as well. And all of that combination of capabilities comes together to ensure that we're addressing those outcomes specific to gaps in care.
Wow, that's amazing. Thank you so much, Cynthia. I think that closed loop approach with kind of integrating claims data and claims information is really the key here, and that next level of what we're able to do through our platform. So thank you for highlighting that. And then I just want to take a look at an example member journey just to see it from the perspective of a member. Could you walk us through one of those?
You bet. And this is a nice way to sort of bring it home. So from a member's perspective, let's call our member Kayla, and let's follow her journey. She's a member of a particular plan, and her plan identifies her as disengaged from care. Let's say she hasn't seen the primary care provider for a wellness exam in over 18 months. So the health plan could, in this case, works with our Amwell marketing team to let her know, to engage her, and inform her that she can get preventative care from the comfort of her home through a virtual primary care visit. So Kayla goes online, she finds her care access point through her member portal. It's all, she doesn't have to download anything new. And through our smart navigation capabilities, she is able to quickly schedule a wellness visit for the next day. And that is a reasonable turnaround time for us with our primary care offering, with a provider of her choice. So she comes in, she completes the pre-visit questionnaire on PHQ and GAD, and her primary care clinician reviews the history, then meets with Kayla, performs an exam, which, as I said, we actually can do, and discusses the clinician's impressions, orders any additional lab testing or referrals like breast cancer screening, and then documents any gaps in care that remain, addresses those gaps, and where possible, actually closes them at the time of the visit. So in this case, Kayla's GAD and PHQ scores show that she has symptoms of mild depression. So the Amwell Medical Group primary care clinician refers her to our digital behavioral health program, does it all within the context of our platform, our integrated platform. The DBH, Digital Behavioral Health Program, is a self-paced program with coaches that support members in managing their behavioral health needs. So it is self-paced, there's no wait time, and works for somebody, particularly like Kayla, who's a busy professional. So in addition to that referral that she then goes in and engages in, the provider requested screening blood work and put that in her plan, order that directly into the plan lab location. And Kayla goes, schedules the appointment, gets the results done, and the results come back directly into our platform and are surfaced to her primary care clinician on our platform. And the virtual PCP reviews them from the record, sends Kayla a secure message with the results and any next steps. So we don't require somebody like Kayla to come back for every engagement that we have. We really try to leverage our secure messaging very heavily where appropriate. Now, there are times where you have to come back in. We're never going to deliver a diagnosis of cancer over, secure message, but thankfully that doesn't happen too often. But we have many modalities for communication. So let's say a few months later, Kayla notices an unusual mole. She sends a photo via secure message to her virtual primary care provider. The provider reviews it and says, this doesn't look right. I can see it, but I'm going to refer you to a dermatologist anyway, so let me go ahead and do that. So the PCP basically refers Kayla to our partner dermatology program, Derm on Call, for review and management. The dermatologist is able to address her needs within a few days, which is much faster than a local dermatologist. These, in general, they're often not available for 6 to 9 months. So for new patients in particular. So the Derm on Call doctor, the dermatologist, agreed that it was suspicious. So advised the virtual primary care clinician to set Kayla up for Mohs surgery with a local skin cancer specialist. PCP had the dermatologist's data as soon as it was sent to Kayla. And so the PCP could support Kayla in identifying the key local specialist and get them in within a week for biopsy. Again, really difficult outcomes to be able to achieve in a strictly brick and mortar environment. And the results came back as a non-metastatic basal cell skin cancer, which, if anybody knows, that's the end of that. So good news. It was managed appropriately and frankly was able to be expedited. So I'll stop there. Hopefully that gives a good example of some of the capabilities.
Yeah, that was great, Cynthia. Thank you so much. I really appreciate you walking us through that journey. I think overall, the really nice thing is that Kayla knows that she has this care resource and she can come back to it when she has any kind of minor concern. She's really engaged in her own health, engaged in her own care, and using the resources that the plan has invested in. And so that's really a huge portion of just what we want, what we're trying to achieve, and a huge barrier today in how most people approach care. All right, let's switch context a little bit. A lot of what we saw in Kayla's journey is, to your earlier point, happening on our technology platform. It's being driven by data flow, right? Claims data coming to us from the plan, data that we're pushing back to the plan, medical record information that we're accessing that the member has generated over time, right? And so let's take a little bit of a look at how the plumbing is really working and the additional value that a really good infrastructure brings. And I'm thinking specifically about the operational benefits here. If you could walk us through some of those.
Sure thing. So full disclosure, I am not a software engineer, but from a clinical perspective. So if, when we talk about the plumbing, so to speak, there are lots of experts that we can bring to the table for payers that have more detailed technical questions. But suffice it to say, what Lynn was describing is it's really made possible through clinical integrations. So payers can realize the value of your network of preferred programs, your network of preferred providers, your data infrastructure, so that payers are able to serve their customers more effectively. Milestones are achieved through different programs, whether it's a clinical partner program. So we've got examples such as Vita, Hello Heart, SWORD, Dario, Dermatology on Call, a whole host of clinical partners that we can help bring to the table. But many of our payers have ones that they prefer. And by working with Amwell, whether it's bring your own program or whether it's leveraging these highly vetted programs as well, that data actually becomes integrated into the data infrastructure that both our clinicians have and that we can report out on. So really important when we're talking about gaps in care, if I have a member that I'm managing with gaps in care information and they have a PHQ that's done on SWORD because they did physical therapy through SWORD, my clinicians can actually get access to that PHQ data, and it's integrated into our whole person perspective of what we report out on. So as milestones are achieved through these programs, not only can Amwell Medical Group understand that, it allows for claims-based billing through a single TIN, this whole integration. So there's the data piece, but there's also the integrated billing through the single TIN and bidirectional clinical data flows. So a whole host of benefits, both clinical as well as operational. And when I say operational, I'm talking about plan operations in particular. So because you're working on the Amwell platform, payers are reducing their operational costs and really reducing the administrative friction with just one contract, one clinical services agreement, because we actually, for most of these payer programs, we actually credential them under Amwell Medical Group. And so that's one implementation effort, unified billing and unified reporting. And these efficiencies will really add up over time.
Thanks, Cynthia. Yeah, I think the stat that really jumps out to me that I've read in the past is that most payers have over 9 clinical partners or clinical solutions in place. So if you can imagine doing 9 contracts, 9 implementations, getting 9 different bills, and having to consolidate reporting across 9 different partners, that's really a lot of extra work, a lot of extra lift that every team is doing. And I know that most teams now are doing more with less. So I think we can all relate to that. All right. I think we have one last question around managing performance. I know you spoke a little bit about this already, but if you could give us a high-level review on maybe just a few of the metrics that you're really looking at.
You bet. You bet. So there's a whole host. We measure both operational and clinical outcomes specific to each of our business lines. So it's not just broadly across Amwell Medical Group. We really drill into each of the business lines, whether it's urgent care, therapy, psychiatry, et cetera, virtual primary care, everything from wait times, length of visit, appointment availability, prescribing, documentation to standards of care, gaps in care for key HEDIS measures for primary care and behavioral health. We also measure for patient experience. We measure response times for our customer service teams and a lot more. So what you see in front of you are some of the urgent care values. Less than a 10-minute average wait time. It really can vary from, throughout the year. If we're looking at summer, it's closer to immediate or, less than 2 minutes. If we're looking at, the day after Christmas, maybe it's closer to 13 minutes. So, but suffice it to say, our averages are well under 10 minutes. We're very, very focused on appropriate prescribing in urgent care, as well as our virtual primary care and our psychiatry practices. So really ensuring that we're performing to that standard of care. And our antibiotic prescribing rate as of this year so far is less than 8% inappropriate antibiotics prescribing. What that means is not all prescriptions. Overall prescribing rate is a meaningless, it's a really meaningless statistic. It depends on the patient mix. So when you look at antibiotic prescribing for the top 5 viral conditions, it should be, in the perfect world, 0. It's never going to be 0. The average, the national average, depending on which study you look at, ranges anywhere from 33% inappropriate antibiotic prescribing to 70%. We're less than 8%. And that is not by accident. We work very hard to train our providers. We have a whole quality initiative around this, along with several others. So patient rating of providers, patient ratings of the experience, those are consistently 4.85 to 4.9. And also our customer service. 85% of cases that come into our customer service team are addressed and closed within the first pass. So that's really important to us. Nobody wants to call a customer service rep and have to call back several times. So that's just some of the detailed examples, but we've got lots.
Great. Thank you so much, Cynthia. I think it's really great to just see how much thought and care is put into it and how tightly you're running all of these operations. Okay, that is the end of our prepared presentation. We have a few questions that have come in from the audience, and I will just flag a couple of them since I think we have about 8 minutes left to the top of the hour. First question, I think, Nicolette, this one's for you. What are you really looking for when you're recruiting Amwell Medical Group doctors? What maybe a kind of a profile question, essentially?
Yeah, I think we have a few. What we're really looking for is a clinician who's willing to participate in a medical group. All of the things we talked about today, clinical, operational, the whole patient care. We want members of our group to really be able to and desire to follow that paradigm. And so that may look like a clinician who has a couple of years experience looking to pay off medical loans or med school loans, or it may be someone who's nearing retirement and would like to work on a per diem basis to keep their skills up, but maybe transition out of a bigger hospital system or private practice. And so what's really important to us is that they have that experience coming in and that they want to continue to deliver the high quality care with us.
Wonderful. Thank you, Nicolette. And then I guess this next question looks like it's for you, Cynthia. And it's a crystal ball question. So looking forward, what do you see as the future of virtual care? Are there trends that you're seeing that stand out to you?
Yeah, that's actually a great question. There are a couple of trends. And the first one that I'd say is I'm gonna focus on 3, the first of which is related to the other 2. When Amwell Medical Group was founded in 2012, virtual care, telehealth, was almost unheard of. And it was sort of a odd little question out there of, you can see a doctor online, is that real? And the focus was all about access. We just need to get people who can't get to a doctor access to a doctor. And convenience was part of that. So maybe they had access, but it was inconvenient for them. So access and convenience. It's completely shifted. post-COVID, I think the access is available for anybody that has insurance. And frankly, for those who don't, you can even get direct-to-consumer virtual care. So virtual care is available in the United States, at least, and access is not a hard thing to overcome. Quality, on the other hand, efficiency, and ensuring that which implies you're driving down costs and driving better health outcomes, that's where the money is. That's not just, when I say money, that's where the value is. And how do you do that is really what's sitting in the crystal ball. So how you do that involves new payer or payment incentives, whether it's incentive-based contracting or value-based care. And if you're going to do that, you better have quality outcomes. So you have to be able to demonstrate that your patient population is actually getting better than it would have had they not been seeing your medical group. So you can't do that without outcomes data. So it's much more data-driven than it was. It's much more, many of the changes are going to be focused on new payment models as well as driving efficiency. Okay, so what does it mean to drive efficiency and drive outcomes? Well, there are thousands of point solutions out there. You go to any of the conferences for health tech and you could spend literally 3 days wandering the conference vendor floor and talking to some really creative individuals that have remarkable point solutions. Most of those, if you just look statistically, most of those, I think I read somewhere that most health tech startups, over 90% of them fail within the first 3 years. And why is that? Well, frankly, there's a whole host of reasons. But the key for those that are going to be successful are those that actually really meet the need of capturing and driving outcomes and improving efficiencies. Well, what are we all hearing about right now? AI, AI, AI. So AI is another big trend. So outcomes-oriented care that drives efficiency and quality and has a payment model that is incentivizing all parties to drive that outcome and leverages efficiency that much of which is going to come through AI. So I don't think we're going to actually, this AI genie is out of the bottle, I'll put it that way. And so there's a lot of really remarkable good that can come out of it, some really incredibly creative solutions that leapfrog the technology that we have today. And there's also a lot of potential for challenge that Amwell, for example, has set up an entire AI governance committee and to ensure, safety, security of the data, ensure that it limit anything that we would use, limits all of the potential pitfalls. So I'll pause there because that's an entire other webinar, but suffice it to say that AI is here to stay in healthcare.
I think you're right about that one. We're using it even ourselves, to your point about our AI governance committee and in how we use it to drive member experience. So I think, honestly, everything that you said is, I have huge optimism for the future, for what we're going to be able to do. And I think one thing is clear to me, that you can't do any of this without a really great technology backbone, a great partner to help bring it all together. And of course, a great medical group to do the human element and to use that technology. So thank you so much, Cynthia and Nicolette. Really appreciate it. You taking the time today to talk to us, to peel back some of the layers on Amwell Medical Group, on Amwell itself, on our technology. And we look forward to answering other questions that come in, to staying in touch with everyone in the audience today. Happy to discuss how Amwell can help solve your specific challenges and bring forth your strategies. Thank you everyone very much, and have a great rest of your day.